glad you all made it, and we want to encourage you. Those salad bowls are very full and very healthy, so please get up and help yourself if you would like more. Welcome to the Prenatal and Infant Care Network Luncheon, and we have a lot of great things going on today. The first thing I want to do is to thank Parkview for providing the food for us today. This network benefits from a very nice relationship with both the Parkview Health System and the Lutheran Health System, and they have generously been underwriting our lunches every other one. So thank you very much, Parkview, for lunch today. Paige, do you want to I'm Meg Disler with the St. Joe Community Health Foundation. Paige, I'll let you talk about why we're here today.
All right. Do I need a microphone? Can you guys all hear me? Or I'll talk in the microphone. I have like a fear of talking in microphones. Anyways, I'm Paige Wilkins, Director of Healthier Moms and Babies. Thank you all for coming to the summit today. Part of the reason why we're having it here at this venue is because I know some of you know, but we had moved here in October. We have experienced a lot of growth over the last 6 months, and we grew out of our space at St. Joe Hospital, and we found this lovely space at the summit. The summit houses probably 20 different nonprofits currently, and it's really nice being here because we get to be part of a collaborative group of different nonprofits working together on how we can improve our community, and especially the Southeast sector. I think we have lots of good things in the works that hopefully over the next year or so, you'll see more from the summit. In regards to some of the things that we have going on at our organization, we were awarded through the Indiana State Department of Health to start Nurse Family Partnership, which is an evidence-based home visitation program where nurses are paired with a first-time Medicaid mom, and they work with them throughout their pregnancy until the baby turns age 2. So we have a whole new home visitation program that we're offering in addition to our prenatal home visitation program. We also started Baby Me Tobacco Free, which is an evidence-based smoking cessation program, and this program is incentivized. So if we can work with a mom 4 times before she has her baby, and she agrees to quit and stay quit until the first year that the baby's born, she gets a $30 voucher for diapers every month. If she has twins in the home, she'd get a $60 voucher. If, for instance, Jackie is more, correct me if I'm wrong, Jackie. Oh, 25. Oh, okay. So this is Jackie's baby. She should be talking about it. But so they can earn up to $50 in vouchers. They get partners involved, grandparents, other caretakers that live in the home with the baby. They can earn more vouchers. It's a really great program. The research shows that women that go through it have a 60% success rate of quitting smoking and staying quit. We have also then started, with help through Lutheran Health Network, our Mama Moods group, and this is a perinatal mood disorders group, which is very similar to what they currently offer on Wednesdays out on their Southwest campus. We're going to be offering it here on Tuesdays from 5 to 6. It's open to anybody during pregnancy till the baby turns age 2. They don't have to be eligible for our home visitation program. They can just show up at the group every Tuesday. We will be providing transportation, working with Community Transportation Network. So if anybody needs a ride to the group, if they just give us a call by Monday at noon, we can make sure they have a ride to and from. That's about it. I think the best thing to do for us right now, since we are offering more and more programs for pregnant women, is don't try to decide for yourself which program they're eligible for. If they're pregnant, just refer them. We have an assessment worker who is our rock star, Ashley, over there, with knocking out all of the assessments and really determining what program our clients would be best eligible for. I have brochures and flyers that I'll pass around to you. can do a tour afterwards.
Yeah. If, at the end of this, if you would like a tour of Healthier Moms and Babies, we'll kind of let you know where we'll be convening, like right at the entrance, and you can go see their offices, which are really very nice.
It's under construction zone right now.
The Prenatal and Infant Care Network, this group, one of our goals is for you all to know who else is in the community for you to refer to. So what we have a really tight agenda, but we do want everybody to introduce themselves in your role, and one person per agency. Just give a quick summary. It's got to be, we're going to ask you to keep it less than a minute, of what services you provide, because we have a lot of new faces, so you know who is here in the room and how to refer and how to connect with others in the room. Let's start with you, Mary.
Okay. My name is Mary Hess. I'm the Director of Health and Wellness for Fort Wayne Community Schools. Fort Wayne is trying to better support our pregnant teens, and we've been doing that by collaborating with many of you. Healthier Moms and Babies has been helping us, the ECHO program, Parkview Community Nursing, just to name a few. So that's
Janine Klingenberger, Clinical Director at Neighborhood Health Clinics. We have a prenatal program for patients. We collaborate with St. Joe Medical Foundation, or St. Joe, Community Hospital, and the Fort Wayne Med Ed education with the residents who see our prenatal patients there.
Sarah LeBlanc, IPFW. I'm an assistant professor of communication. I have been tasked with starting a health communication certificate or minor, and I work with Sarah Giaquinta at CHIP in terms of her research efforts.
I'm Heather Wolf. I'm a pediatrician at Lutheran Children's Hospital.
I'm Michelle Savio with the Indiana Department of Child Services.
Sarah Turner, I'm with St. Joe Medical Group.
You'll hear from that group soon.
I'm April Mord. I'm with SuperShot, and we serve kids that have Medicaid, have no insurance, or they have insurance but it doesn't cover certain vaccines. Right now, we're not able to serve children that are fully insured. We also serve adults. That's kind of new in the last few years, but we are able to serve adults that do not have insurance, or if their insurance doesn't cover certain vaccines. All the vaccines are $10 a shot, and you can see all of our clinic sites at supershot.org.
I am Shelley Meredith, the Infant Toddler Specialist at Early Childhood Alliance. And Early Childhood Alliance, our mission is just to make sure that there is quality child care available to the children in our community. In addition to Allen County, we serve 9 other counties in Northeast Indiana, so we are all over the place out here. We work with families to connect them with childcare and let them know what quality childcare looks like. We also work with childcare providers to provide professional development for them. We do on-site support. All of our services are free as well, so pretty much anything in the early childhood education field, you can reach out to Early Childhood Alliance, and our website is ecalliance.org.
Hi, I'm Kristen Bunn. I work at Brightpoint with Covering Kids and Families. I'm the program supervisor, and we assist people with signing up for insurance like Medicaid, HIP, and Marketplace. And our services are also free.
I'm Elaine Williamson from A Baby Closet, and with me is Carolyn Gorham. She is the site coordinator. We use an incentive program, so when they get their prenatal visits, well, their super shots, and probably for many of you agencies here, they earn their coupons to redeem at our site for diapers, miscellaneous items, and large items.
I'm Jill Slaughterback, a maternal child nurse navigator at Parkview.
I'm Erin Norton with Parkview, and we are delighted to have just brought Jill on board. She will be making referrals to all of you out here, all of your agencies. So if she hasn't talked to you yet, she will be soon.
I'm Heather Henry with Parkview Community Nursing.
I'm Marianne Wisman with Parkview Community Nursing. I'm Deb Lelling with Parkview Community Nursing.
And I'm Carmen Moore. I'm the manager of Parkview Community Nursing. There's a lot of feedback here. A lot of feedback. Sorry about that. I really don't need a mic. I'm like you, Paige. Don't need a mic. We basically provide services and support for almost all of the agencies here with community nursing. We work with the underserved, underconnected in our community in Allen County and the surrounding counties. And we provide safe sleep classes and breastfeeding support groups and tobacco cessation classes. We work with the homeless populations. All of our services are funded by Parkview Community Health Improvement dollars.
Joy Tiernan with the Hope Center. I'm the center director at Hobson Road and the mobile operation manager.
Kathy Wilson with the Hope Center, development director.
Joe Faulkner. I'm the executive director, and we do everything from free pregnancy test to STI testing to Earn While You Learn, which is where our clients come in and they earn things for seeing videos and also doing other things that help the improvement of their baby's health. And we also have a mobile that is going out into other areas right now, and we're having a great deal of success with that, and we're just thrilled to be able to do it. And we also have our website, ahopecenter.com. Please look at it, and you can find out everything that we do.
I'm Leanne Fritcher. I'm the director of nursing at Hope Center.
I don't like the mic either. I'm Lisa Griswold, manager of Mother Baby at PRMC.
Beth Stutzman, center director of a Hope Center on South Calhoun.
I'm with Lisa.
I'm Courtney Winker, nutrition coordinator at the WIC office.
Tyan Achenball, WIC director. We provide services to women, infant, and children, and provide nutrition education and lactation support.
I'm Cindy Stahl. I'm with the Christ Child Society.
And I'm Diane Besden with the Christ Child Society, and we provide layettes, we provide coats, we provide backpacks, we provide reading assistance at a couple of schools, just to help the needy children. And I am president of Christ Child Society this year, and we work with the Women's Care Center.
I'm Ann Kao from the Women's Care Center. I'm the director of the 3 centers here in Fort Wayne. We offer also free pregnancy testing, limited ultrasounds, help mom bond to her baby. We have parenting classes, birth preparation classes, one-on-one parenting if that's best for them. And we have 977 babies coming in the next few months, so we're busy.
I am Stacia Roth with A Mother's Hope. We are going to be a home for pregnant mothers who are homeless or at risk of homelessness. But more than just a home, we hope to also offer them hope and programming to help them get back on their feet. I know the burning question in everybody's mind is, when are you opening? So I will just answer that as soon as possible. As I'm sure you can imagine, we've hit a few snags in our renovation, as all renovations do, but we hopefully are hoping to look towards end of March, April still is the plan.
I'm Megan Teston. I'm the assessment supervisor with Healthy Families. We're a home-based visiting program. We serve moms that have kids ages 0 to 3, so they can stay in the program until they're 3. We work on everything from child development, case management, community resources, and just supporting them.
Hi, I'm Karen. Pardon me. I'm Karen Richards with the mayor's office, and I am here to watch and see what everyone is doing so I can report to him. I know he meets with many of the groups individually, but I have been given this bestowed a couple years ago to attend these functions and be the liaison, and it just thrills me to see what you are all doing. I just feel that you are our angels in our community, to be truthful. So.
I'm Stephanie Good with DuPont Hospital. We provide free education to families. We have car seat checks that we do through Allen County Safe Kids. We have a safe sleep program. We have a breastfeeding support group, as well as they provide lactation consultation appointments when needed.
I'm Janet Elmer. I'm with Stephanie Good also.
I'm Jenny Keller. I'm the manager for neonatal and maternal fetal transport at Lutheran Children's Hospital.
I'm Lillian Rosebrock. I'm a student at IPFW. I'm a senior in human services, so I'm coming here just to learn about what you guys do.
I'm Danielle Nyes. I'm also an IPFW student. My major is health and human services with a minor in psychology, and I'm an intern at Brightpoint in their early Head Start program.
I'm Tammy Pfeiffer, the Early Head Start manager at Brightpoint. We are also a home visiting program, and we serve pregnant women and families with infants and toddlers who are low-income families. And we work on school readiness and closing the achievement gap through health services, education services, family stability services, and our wait list is low, so we could use referrals.
Marlene Krause, and I'm the health coordinator for Brightpoint Early Head Start.
My name is Jackie Martinez, and I work with Healthier Moms and Babies.
I'm Shirley Lothamer. I am the nursing supervisor at Healthier Moms and Babies Nurse Family Partnership.
My name is Tanisha Clements. I'm the coordinator for Park Center's Three Wishes program. We provide supportive services for children who are having difficulties functioning in traditional environments. That's home, school, preschool, Walmart, the back seat of a car. And then we also provide services for pregnant women or women of young children who are struggling with mental illness.
I'm Amanda Wyatt, and I'm the therapist with the Three Wishes program.
I'm Julie Reese, and I'm a nurse case manager at Healthier Moms and Babies.
I'm Mary Luderman. I'm also RN case manager with Healthier Moms and Babies and the Nurse Family Partnership.
I'm Marcia Misla, and I'm a nurse home visitor with Healthier Moms and Babies Nurse Family Partnership.
My name's Danielle Furge, and I'm in the same program.
I'm Ashley Nichter. I'm a case manager with Healthier Moms and Babies.
I'm Alicia Shaw. I'm a case manager with Healthier Moms and Babies.
I'm Chelsea Harris, and I'm also a case manager with Healthier Moms and Babies.
It's a great new service, a lot of good talent coming in.
My name is Zari Gui, and I work at the YWCA with the Domestic Violence Crisis Shelter and the Hope House.
My name is Jamie Farron. I'm the Director of 211 Services at United Way of Allen County.
I'm Melissa Singh. I'm a case manager at Catholic Charities here from the ECHO program.
My name is Daffodili. I'm from a Catholic Charity, Refugee Resettlement Case Manager.
I'm Pat Turner with Tobacco Free Allen County. I'm the Tobacco Education Coordinator, where we provide services to help people recover from tobacco addiction and then provide education about the dangers of second and third-hand smoke in the community.
Good afternoon. I'm Connie Kerrigan. I work for Parkview Behavioral Health. I'm responsible for outreach and working with our navigators, and we're currently in the process of developing a neonatal abstinence navigation program as well as peer support for the emergency departments.
I'm Meredith Stout. I'm the Director of Professional Outreach at St. Joseph Hospital and the Lutheran Health Network.
Hi, I'm Kathy Thornton. I work with the Health Department. I'm the Director for HIV and STD. We have all of our clinics out on New Haven Avenue where there are things like immunizations, the refugee clinic, the STD clinic, and we also do all the surveillance components for the partners to various communicable diseases.
I'm Liz Murray. I'm a psychiatric care navigator with Parkview Behavioral Health.
Good morning. My name is Melissa Hall. I am a student intern with Parkview Behavioral Health.
Hey, I'm Holly Seabury with Macmillan Health. With infant mortality, we primarily do development of educational resources and training for other groups.
Okay, we are going to move quickly to some of the more very interesting not going to say we're not all interesting, but I think you all came to because you wanted to hear some of the panelists and the speakers. The first person I have the privilege of introducing is Dr. Sarah Turner. She has a unique practice here in town. We have a brief little bit of information on the agendas that were passed out, but she runs the Monarch Clinic, and she has this very special love for working with high-risk in surgical obstetrics. And I'm going to kind of just turn it over to you and explain how fortunate we are to have you in our community.
Hello. My name is Sarah Turner. I'm a family practice doctor and lactation consultant. I did my residency here in Fort Wayne 2011 to 2014, and then went and did a fellowship in high-risk and surgical obstetrics in New Mexico, where there is a huge, huge drug problem. And so we had this awesome opportunity to work with mostly women who had issues with currently or in the past with substance abuse. So I was really terrified to start working with them, and then after a couple weeks totally fell in love with it and decided I wanted to come back here and start my own program, and that's what I'm doing. So I'm just going to talk a little bit about substance abuse and use in pregnancy. I have no disclosures, except that I have gorgeous children, and I have to share them in my presentations. So I'm just going to talk a little bit about how to screen and identify women with substance abuse, how it affects pregnancy, and how we can help women. This is a shortened version of a presentation I gave to the residents, so some of this isn't here. But community resources, we're all here, so. All right, so substance use and abuse in pregnancy. Reproductive age women are the highest substance users in the United States, and so they are at the highest risk. And this is often a time when women will, for the first time, come to care. They get pregnancy tests, they've decided they're gonna do it right, and they wanna get clean, and often will have one opportunity in that pregnancy. They'll show up one time to one person, and if they don't get what they need, they're gone until they deliver. Pregnant women in 2012 in the United States, 5.9% used illicit drugs, 8.5% drank alcohol, 15.9% smoked cigarettes, and the most commonly used substances are nicotine, then alcohol, then marijuana, and then some of the heavier drugs. Polysubstance abuse use, in about 50% of them, not surprisingly, most of them smoke cigarettes if they're using drugs or using alcohol. Very rarely, actually, well, not very rarely, but it's not as common to see women who are using drugs and alcohol. It's usually one or the other. Pregnancy, again, is often a time of recovery, and abstinence was shown in one study in 96% of women who drank alcohol, 78% of women who smoked marijuana, 73% of women who used cocaine, and 32% of women who smoked cigarettes. Now, the sad thing about this is the relapse rates at 3 months were really high, 51% in alcohol, 51% in marijuana, 27% in cocaine, and 58% in people who are smoking cigarettes. Now, this is, the first 3 months postpartum are incredibly stressful, and so it's one of those things where you can be, oh, you know, I get it, you're under stress, but this is also one of the most important times for women to bond with their baby and sort of develop, you know, a lot of those, I'm trying to think of the word, not maternal instincts, but where they sort of get into a groove of motherhood, and if they miss that opportunity, often they have a lot of struggles down the line. Substance use and abuse in pregnancy is associated with decreased prenatal care. A lot of women are really scared about getting in trouble or their baby being taken away or, you know, being looked upon like they're garbage, which most of the women who come to my clinic are shocked that this is something I want to do and not something that I'm forced to do. And hearing all their stories, it's definitely this idea with a lot of people that this is a choice and they're bad people and they're horrible mothers and they should just give up their babies and be done with it. And I know that they're, you know, the resources in Fort Wayne to help them are here, so getting them to prenatal care and helping them recover will increase their prenatal care. It's also associated with poor nutrition in pregnancy, increased morbidity and mortality both in the pregnancy and then the neonatal time. There's growth restriction, preterm delivery risk, fetal demise, SIUD, and SIDS. Increased complications to their pregnancy. These women definitely have higher rates of preeclampsia and hypertension, placental insufficiency, abruption, infections. And a lot of these perinatal complications are very dose dependent, so if they're smoking marijuana, you know, once a week, they're not going to have as many complications as they're doing coke 3 times a day, which makes sense. So other than alcohol, there's really no clear association with birth defects. Most of it's more gross and just, the associated complications listed above. Other associations, there's a history of or current issues with domestic violence, sexual abuse. Most of these women that I've seen, of the patients that I currently have, all of them have history of abuse currently or in the past. Mental health issues, all of them have depression, anxiety, PTSD. Food insecurity, housing issues, poverty, lack of transportation, increased rates of HIV and HCV, chronic medical problems like asthma, diabetes, hypertension. So lots of needs. So who do we screen? Well, everybody. And we're really working towards this in our task force to get that everybody on board, all the obstetricians, all the family practice doctors doing OB, that every single person screens every single patient. If it's across the board, no one's going to be offended that they got screened, and we'll catch a lot more people and be able to help a lot more people. It only takes 30 seconds when it's negative, 5 to 10 minutes really when it's positive and you're trying to figure out who to send these women to. How do we screen? Drug testing for everyone. Urine drug tests really underestimate the use, but they're better than nothing. Do we use our intuition? No, because if we use our intuition, then we do selective screening and we do it to people that we think will probably be users and not do it to people that we don't want to offend. Ask them if they're using? No, most people will actually totally underestimate what they're using. So we want to screen for alcohol, tobacco, illicit drugs, prescription drugs. So using questionnaires, rapid drug screens at the first prenatal visit are things that we're working on. And not using alcohol, using beer, wine, and liquor, because a lot of people hear alcohol and they think of spirits, not wine. So, and we want to go beyond the do you use questions. Have you ever woken up in the morning and felt like you needed something to get on with your day, stuff like that. Some of this is not relevant. So the harm in screening women. So the harm in screening women, there's this criminalization of expectant mothers, and thankfully in Indiana this isn't an issue, but in some states, like South Carolina, they were preferentially screening African Americans, and it was done without their permission, and the results weren't even discussed with the moms. They handed it right over to the police, and these women were sent to jail. And instead of helping the moms, heal themselves and keep their family together and heal their partners, there was a violation of their Fourth Amendment rights and they just went to jail. Baby was taken away. The end. In Tennessee, they signed a bill in 2015 that requires drug testing of all pregnant women. And if they were positive, they were charged with aggravated assault. So up to 15 years in prison. This is not a solution. And it's opposed by the American Medical Association, the American College of Obstetrics and Gynecology, ACLU, a lot of the other medical associations, except Tennessee. Tennessee's medical association is in agreement with it. And there's really no national consensus on laws in terms of what to do with this. 18 states consider it child abuse. 15 states require reporting. So if we get a positive screen, I can't just discuss it with the mom and figure it out among ourselves. I have to call the police. 4 states require testing if it's suspected. This, again, leads to preferential selection in terms of who to screen. Indiana, in 2016, passed a Senate Bill 186, which prohibits us, as physicians or other individuals involved in prenatal care, from reporting and involving law enforcement, which is great. I think this is a fantastic bill because it means that women can come to us and confidentially get treatment. Now, if we're concerned, we can obviously get the right people involved, but there's no law that says we have to report, so women are more likely going to come and ask for help. This includes questionnaires, urine, blood, and we need patient and consent or a court order to release results to law enforcement. And our job, as medical professionals and people in the medical community is to do no harm. And so prenatal care is very important. We want to make sure these women can trust us. We don't want to dupe them into coming in and reporting them for behavior that we should really be helping them with. Our relationship with our patients is really important. And my biggest thing with my patients is it takes me months to get them to trust me because they've never trusted a lot of people before. And so maintaining that relationship is important. I talk to them about how I will be drug screening them, and if they can't stay clean, the right people will get involved, and they may lose their baby, and they understand that with conversations. But a healthy pregnancy and a healthy baby is really one of the most important things. And I do a lot of ultrasounds in my office when women relapse. Look at your baby. You look at that baby, and you think about this every single time you feel like using, and it really does help them a lot. So just going into a couple of the drugs that are commonly used in pregnancy, marijuana, it's really controversial as to its its effects in pregnancy. There are studies that show a lot of different things, but there's really not a lot of consensus. And not a lot of solid data. A lot of the studies are very small and don't have a lot of power to them. So the placenta seems to limit a lot of the exposure. So the amount of marijuana in the mom's blood really is a lot higher than in the baby's blood. There have been some studies that show to alter brain neurotransmitters in chemistry, so that can affect baby's cognitive development later in life potentially. Increased carbon monoxide exposure obviously isn't good and can decrease fetal oxygenation. And so many view that it's okay because it's legal in certain states like Colorado. And alcohol is legal. And tobacco is legal, but we know that those are not good in pregnancy, as well as multiple medications that could hurt your baby are legal. So evidence really, again, is not consistent. There's studies that show it increases rates of preterm labor, low birth weight, small gestational age, admissions to the NICU, poor academic achievement, more behavioral problems. A lot of those, though, can be related to other things that are going on, especially when we're looking at poor academic achievement and more behavioral problems. Those can be related to their environment. A lot of people who are more likely to smoke marijuana during pregnancy aren't necessarily as likely to read to their children as other parents might be. The most consistent evidence is really decreased attention and executive functioning skills. So there is evidence that it does do harm. But again, there can be a confounder with other substance use and abuse because a lot of people aren't just smoking marijuana, they're doing other things too. Again, also a confounder with socioeconomic factors. And there was a study, one of my attendings in fellowship always quoted this one study, that Rastafarians, they followed this large group of Rastafarians who, as part of their religion, smoke a lot of marijuana, and there was no change in outcome for babies. So it's still not recommended, but what it actually does to pregnancy, we're not really 100% solid on. So cocaine in pregnancy, we know, is bad. It can affect brain development, chemically and structurally, cognitive development, executive functioning. We see increased rates of spontaneous abortion, growth restriction, low birth weight, small for gestational age babies, placental abruption, which leads to emergency situations and fetal death. Preterm rupture of membranes, preterm labor and delivery, uterine ruptures, stillbirths and fetal demise, SIDS and SUID. It's also associated with moms having cardiac problems during their pregnancy, heart attacks. And then the fetal exposure, again, varies really widely with maternal use. So if they're using the same amount every single day, some days the babies receive a lot of it, some days they don't. So there's no safe amount is really the point of that in pregnancy. The opioid epidemic is really the biggest thing that we are here to talk about. Every day in the United States, there's 650,000 new opiate prescriptions, new ones. This patient has not had one before, which is huge. 3,900 people start using prescription opiates without an indication, so that may be prescribed, but without an indication. 580 people start using heroin every single day, and 78 people die of an opiate-related overdose every single day, which is ridiculous. The treatment programs really cannot keep up with this demand. And there's an increased need for treatment programs for women. And this was kind of the point of my fellowship. They wanted to train us and then send us off all over the country to try and start our own programs because there's just not a lot of them. Type of opiates, there's tons of different types, short-acting, long-acting. Birth defects are usually actually pretty rare, and it's usually more due to other things, not the actual heroin or opiates that they're using. But it is associated with fetal growth restriction, placental abruption, preterm labor, fetal demise and stillbirth, respiratory problems in the baby. And dependence leads to withdrawal syndromes for both mother and baby while she's pregnant, and it usually starts 4 to 72 hours, can last weeks on something like methadone, depending on their dose. The official recommendation is not to stop opiates during pregnancy. The official recommendation is to do medication-assisted treatment. And that's just because the studies have shown that the relapse rates are so high, it's not successful. Withdrawal from opiate use during pregnancy is associated with poor neonatal outcomes, including early preterm birth or fetal demise, higher relapse rates. Robust evidence has demonstrated that maintenance therapy during pregnancy can improve outcomes. So that's where we are from the ACOG. So medication-assisted treatment in pregnancy, there's two options. There's methadone or buprenorphine, which is Subutex. Methadone's been around for many, many, many years and has been sort of the standard of treatment for many, many years. Subutex is much newer and has a lot of advantages over methadone. Now, using MAT improves prenatal care and improves nutrition among women. There's increased birth weight from babies, reduced infections both in mom and babies. Reduced crime of moms, so they stay out of jail. Similar maternal and delivery outcomes as if they were to continue using. And both have risks of the neonatal abstinence syndrome. Detoxification, again, is officially not recommended, but it's often pursued by people. And there is a lot of studies right now that are going on in the obstetrics world as to good ways we can, or when we should do it, or how we could do it appropriately and keep rates low and stuff like that. But again, from the small potential risk of fetal loss, preterm labor, lack of effectiveness with the high potential of relapse. And there was a retrospective study that 300 women who detoxified, 17 to 18%, they were incarcerated, so they went cold turkey with slow weans, and then there was an inpatient detox. NAS in 70% of the babies who had the inpatient detox without the intensive outpatient follow-up. So methadone. Methadone's a long-acting opiate, and so its half-life for someone who's tolerant to opiates is about 24 hours. It has to be dispensed by a treatment program, and that includes daily dosing. After they've been doing it for a long enough time, they can usually get permission to have, a couple days of take-home, I think up to a week if they've been there long enough. One thing I didn't mention up there, it's pay for out of pocket. There's no coverage by Medicaid currently or any insurances currently, so I believe it's like $15 a day, regardless of your dose. The doses are based on cravings and withdrawal symptoms, so they're assessed every couple of days for increases. And during pregnancy, we definitely expect that they're going to increase their dose just because of the physiology of pregnancy. And it says 80 to 120 milligrams a day. I have a patient right now who's on 185, so it can get pretty high. It doesn't require any withdrawal for induction. So if I have a patient who shows up and she used heroin 6 hours ago, she's still kind of high, I can actually start her on methadone right away, which is an advantage for a lot of patients because they don't have to get sick first. And I'll go into that more in a minute. The dose is not related to the risk of NAS. It's more the stability. So if someone's on 40 milligrams and they're still having a lot of cravings and a lot of withdrawal symptoms, there maybe has a higher risk of NAS than if someone's on 180 and they're actually very, very stable and feeling good. So buprenorphine, Subutex, it's an alternative to methadone. I love this drug so much. I think it's got a lot of advantages over methadone. It's a partial agonist antagonist. So with methadone, it's a straight opiate. And so as women get on a higher and higher dose, they have that risk of feeling kind of tired, feeling kind of not dopey, but just they have that the risk for respiratory depression and sleepiness and stuff like this. Where with Subutex, they have this ceiling effect where they get, a lot of the help with all the withdrawal symptoms and the cravings, but they don't feel tired, they don't feel dopey, they don't feel high, which some women don't like, but it's good. So the ceiling effect is great. It blocks other opiates as well, so if someone's on Subutex and I give them something for pain, it definitely doesn't work as well. That can be an issue after deliveries, after C-sections, stuff like that. But it has a really high affinity for the receptor. This is a really important part. It'll displace other opiates. So if that same patient shows up, she used heroin 6 hours ago, I give her Subutex, it's going to knock all the heroin off her receptors. It's going to bind. It's not going to give her as much effect as the heroin does. So all of a sudden, she's in the worst withdrawal of her life, and there's nothing I can do to help her. So women who want to start Subutex have to get sick before I can give it to them. And some women are just not willing to get sick, and so methadone is the better drug for them. It is abusable, but really the risk is a lot lower than the full agonist opiates like methadone. That's all right. It has a long half-life with once-a-day dosing as the norm. A lot of women aren't using heroin only once a day. They're using heroin like 5 times a day, so they want to take Subutex 5 times a day. I tell them I don't really care as long as they're taking the same daily dose. It has a much shorter half-life than methadone, so they start to withdraw a lot quicker. With methadone, women can potentially miss a day of dosing and not go into severe withdrawal, not the same for Subutex, which a lot of women don't like that. And it requires them to be in withdrawal. So looking at the differences between the two of them, it's very different and it's very patient dependent. A lot of women who have polysubstance abuse and need that daily accountability, methadone's definitely a better drug for them. Women who are using a lot of heroin, often Subutex won't cover their symptoms, so methadone's a better drug for them. For people who live in rural areas, I have women who drive an hour to come and see me. Subutex is a great drug. I can give them a month worth. They don't have to come and see me every single day. Insurance covers it. It's got a lot of benefits in that regard. And generally, You know, the withdrawal rate from babies, babies tend to do better on the Subutex versus the methadone. The official studies say, you know, 40% of Subutex babies, I think it's 60% of methadone babies. And you can switch from Subutex, so I'll often start people on Subutex and it doesn't cover it, I can put them on methadone, but you cannot go the other way, because they generally have to be off methadone for a couple of weeks, and I'm not recommending people go off methadone and use heroin for a couple of weeks until they can come back and see me, so. Other substances, tobacco causes placental vasoconstriction, which decreases blood to the placenta, so they get less oxygen and nutrients, increased carbon monoxide. There's more nicotine on the baby side than the mom side, which is interesting compared to a lot of the other drugs, or substances, sorry. And many of the effects are also dose dependent in studies, but there was actually, after I wrote this presentation, there was a recent study that said kind of if they're smoking 2 cigarettes versus a pack, the outcomes are very similar, so. It's the most common second substance. Perinatal smoking leads to increased risks of ectopic pregnancy, miscarriage, clefting, but the evidence for that is pretty weak. Damage of the structure of the umbilical cord, growth restriction, placental insufficiency, preterm labor, increased infant mortality, and early breastfeeding cessation. Abnormal cognitive development in babies. And secondhand smoke leads to a lot of other problems as well. So a lot of people think, well, I smoke outside, my baby's gonna be fine. I tell them, well, unless you're like having a shower and changing all your clothes, it's really not gonna do a whole lot. So I counsel every single patient to quit smoking, as I'm sure everyone in this room probably would. So alcohol, obviously we know that alcohol has a lot of strong evidence for pregnancy complications, as well as problems with babies' development. There's the craniofacial dysmorphism, the FAS babies that we see. Central nervous system and cardiac abnormalities, withdrawal after delivery can be really severe, and long-term effects on cognitive and behavioral deficiencies, speech and language, executive functioning. Maternal withdrawal as well during pregnancy can be really dangerous for babies. It's associated with hypertension, seizures. And there's FAS, which we all know about. There's also alcohol-related neurodevelopment disorder, which is essentially FAS without the facial abnormalities, but they still have all the other stuff. So if a baby comes out and looks normal, it doesn't mean they're not affected. Evidence for low to moderate use in pregnancy is inconclusive, so generally there's no safe amount, no matter what. We cannot recommend it. So methamphetamine is very similar to cocaine, causes vasoconstriction. Prevalence is up to 4.8% in endemic areas. There is quite a bit of this in Fort Wayne. It's not often the primary drug, but a lot of my women who are using heroin are using this when they can't get a hold of heroin. And it's associated with shorter gestational age, so preterm labor and delivery, premature rupture of membranes, lower birth weight, hypertension, intrauterine infection, fetal demise and stillbirth, development and behavioral issues with children, and the prenatal care. I was supposed to take that out, never mind, sorry. All right, benzodiazepines is the last one. So it's a psychoactive drug, has a lot of properties that people like about them. They calm people down, they help with withdrawal symptoms. It's a depressant, so it's adds to like opiates and alcohol, so it can be really, really dangerous, even and especially when used with methadone or Subutex. Potential for toxicity and overdose, and it crosses the placenta. So evidence, again, is pretty unclear about what it does. No one's really doing studies where they make people take some benzos to see what happens, but most women who are using them are using a lot of other drugs too, which is why we can't really figure out exactly what is caused by it. A lot of different defects, and there's definitely withdrawals after delivery that can take weeks to months. And some of them are very similar to opiate withdrawal. So in treatment, medication-assisted treatment for opiates and cocaine, psychotherapy is really important, addiction counseling, mental health counseling, family counseling, social work and case management for housing, transportation, food insecurity, lack of insurance and employment. Parenting classes are very important for a lot of these people. One thing that I heard at a talk recently, which was something I never really considered, is a lot of these women start using drugs when they're in their teens, and it can halt their brain development. And so we sit at their bedsides and we talk to them like the 40 or 30-year-old women that they are, but in their head, they're really like teenagers. And so we don't have to treat them like teenagers, but we need to approach it like they're not 30-year-old women who know sort of the common sense stuff about being a mom, and kind of give them a lot more guidance and give them a lot more support than the average mom might need. So having prior children doesn't mean that they know how to raise a kid, which a lot of people assume. Recovery for their partners is so, so, so important. If their partner's not clean and their partner's still using, they almost certainly will relapse at some point. And so Clean Slate and the Bowen Center, Park Center, all offer that. Breastfeeding is a place that's close to my heart. As a lactation consultant, I feel like everyone in the world should breastfeed. It's generally not recommended for people who are actively using cocaine, methamphetamines, heroin. If they've been clean for a decent amount of time, though, they all should. It helps babies a lot with the NAS. Marijuana is, again, very controversial. There are studies that are ongoing. Generally, if someone's not a heavy user, it's felt that the breast milk and the breastfeeding benefits outweigh the risk of occasional marijuana use. It's recommended for women on Subudex and methadone when they're in recovery. That's a big question for a lot of my women. Can I still breastfeed? Absolutely, they can still breastfeed. It's great for the babies. With smoking, again, the benefit outweighs the risk. And breast milk, in terms of alcohol, this is one thing. People always think that if you have any alcohol, you have to pump and dump, and they should never, ever, ever pump and dump. What they should do is save the milk and actually mix it with other milk. If they've had a drink, I stress that one a little bit. It's generally not recommended. If you're sober enough to hold your baby, you're generally sober enough to feed your baby. I don't talk to patients a lot about that because I don't want people who are alcohol abusers do that, but it's more sort of my regular patients who are like, I'm so stressed out I could use a glass of wine. Fine, have a glass of wine. So my clinic is the Monarch Perinatal Clinic, which stands for Maternal Obstetric, Newborn Care, Addiction Recovery, and Comprehensive Health. And so my goal is to kind of help these women with everything. I do their prenatal care, I do their medication-assisted treatment, I follow their babies up, I help them with their diabetes and their asthma and all the other stuff. And so it's for mom and baby. I help get their partners into treatment, and we've had some awesome success. It's a place where I want these women to feel special, feel loved, because it's often one of the first times in a long time that they have felt that from people outside of their family. It's a judgment-free zone. I will not get mad at them and kick them out. We try and get all of our women into Healthier Moms and Babies and other social work and case management programs. We get everybody into behavioral health. Part of the deal is they have to be in counseling, whether they're on medication-assisted treatment or not, and referral for their partners. I do the continuity of care with them after delivery. And one of the greatest things is I've probably delivered, I have about 20 patients right now. 3 of them have gotten their other kids back, which has been fantastic. Not only have they kept their kids, but they've gotten their other kids back. Only 2 of my patients were lost to care and lost their babies, which is awful and unfortunate, but all the other ones didn't, which is so awesome, and I'm so happy for that. They're all doing really wonderfully, and we have a long way to go in the community, but I'm so happy that it's working out. So I'm always taking patients, and I will see people within a week, usually within a day. And if any of you ever encounter these women, you can call me. There's a number 24 hours a day I will answer. If they are in acute withdrawal and they need treatment, they can go to St. Joe, and I will come and treat them. So that's it. Any questions? Yes? So Meredith, up at the back, she has flyers. And so it's got the 24-hour number on there. If people don't know the 24-hour number, they can call St. Joe L&D. They have the number, and the patients can go right there, or St. Joe Medical Group. And just to ask for Monarch Services, they'll refer them to that number. So any other questions? Thank you so much.
Give that to Tony.
Okay.
So thank you so much. I learned way too much, which is every time I come to lunch and anybody else, I get kind of depressed, but it's going to be good. So we're fortunate to have a great panel discussion. You know, what's going on locally? What are we doing to address these issues? And what can be done by DCS and others if we find children in trouble and cannot go back with the mother or go home with the mother? So we're going to start with Dr. Tony Giaquina because he brought a PowerPoint and he's going to tell you, and then the rest of the panel will come up and they'll tell you what their positions is, what they're doing, and just talk about it, and then we're going to have an open question and answer.
Thank you, guys. I'll try to do this as quick as I can. I do have to go back to clinic, so I'm a little wired on caffeine, as you can see. Great. So we're going to talk about, let's see here. Which button do I press? The bottom one. Substance abuse disorder, pregnancy, and Fort Wayne's children. Sarah gave a great background talk on the importance of maternal medicated assisted treatment and the big problem that moms face. And so I'm going to kind of flip that a little bit around and look at the impact on children as they are struggling through this process as well. So a couple things that we do need to be consistent about defining, and that is neonatal abstinence syndrome as well as substance use disorder. Substance use disorder doesn't have to be anything complicated. It's a condition that involves an intoxication, withdrawal, or abuse dependence upon a substance with defined abuse or dependence of potential, and that includes alcohol. And then we have neonatal abstinence syndrome, which is the impact on the baby, which is a clinically diagnosed syndrome experienced by drug-exposed newborns after birth. So this doesn't have to be anything complicated either. Sometimes we use things like Finnegan scores to clinically diagnose it, but what we're trying to get away to is a more clinical definition where if we see a baby that is withdrawing and showing symptoms of withdrawal, and mom took a medication that causes withdrawal, well, it looks like a duck, it acts like a duck. That's a duck. That's neonatal abstinence syndrome. And we're trying to get better at defining that and making sure that we are capturing that consistently. So this is important, okay? Substance use disorder is very important. It's something that is extremely prevalent. It's something that is extremely deadly, okay? Think about all the resources that go into car accidents in this country and making sure that cars are safe. This is more deadly than cars, okay? This is something that's new. It's something that is rising. It's something that is rising fast. Overdose deaths are spiking. That's the last date is 2015, and we have not seen a plateau from that, okay? And so the question we want to know is, okay, sure, we're seeing lots of overdose deaths and drug addiction in the community, but are we seeing that in pregnancy? And as you heard from Sarah, the answer is absolutely. We actually saw a decline in substance use dependency down to about 8% into the early 90s. And then what happened in the late 90s is pain management underwent a little bit of a paradigm, and doctors started to treat pain like a vital sign. And so we were giving out lots of pain medications, and at about the same time, we were also seeing an influx of cheap heroin, and boom, we had this big explosion. Has anybody read the book Dreamland by any chance? You guys need to read Dreamland, okay? That will explain why we are seeing the crisis that we're seeing today. So write that down. And then this is what we have. In 1999, 3.4% of pregnant women were current users of illicit drugs during the prior month. And then 2003, we're up to 4.2%, and now we have seen an explosion, okay? The best data we have is probably from Cincinnati, where what they did is they took an entire region of hospitals, so not Parkview, not Lutheran. They took everybody together. There's like 15 hospitals. They said, this is a big deal. We're gonna get together and do this consistently and do it right. And what they found is that's 80 out of 1,000 moms had some sort of drug in their system when they delivered. Okay, that's about 10%, 1 out of 10. Think of all of the things that we are screening moms for: HIV, syphilis, hepatitis B. This is 10%. The prevalence of this is extremely high, and the circumstances and the consequences are dire. And we know that because our neonatal abstinence syndrome is also becoming a growing problem. We haven't seen any plateaus in any of these graphs, okay? They're all going up. This is last in 2012. We're seeing NAS rates of about 5 out of 1,000. That's a big number. And it's expensive. This is our most expensive diagnosis for children when they are hospitalized. Hospitalized children with NAS on average stay in the hospital about 4 to 6 weeks. We're trying to improve that, and I think we're doing a good job of that actually. But look at how much an admission is. This is $93,000. If we can do what Sarah's doing, and we can give these moms the right resources, we can get them switched to appropriate medicated assisted treatment, and we can get them the behavioral health treatment they need, absolutely, our society has a big incentive on addressing this problem prenatally. The infant harms of NAS, as we know, are probably severe. We don't know enough about it because this is a new problem and we don't have the data to look at the long-term effects. But we are seeing that college students and kids in high school are struggling more that were impacted and exposed to drugs at a young age. So how are we doing in our community? That question mark is there for a reason, okay? We have no idea, okay? Sarah's doing a great job trying to uncover this, but we are missing a lot of patients and we're missing a lot of kids because we just don't know. And that's the big problem, is that Dr. McMahon wants to know what the problem is and how should we address it, and we don't have the tools, the resources, and the numbers to either identify the problem or then, again, make sure that we're screening and addressing it. So again, I talked about the Cincinnati region. These are all the hospitals that got on board and said, yes, we are going to put our names on hold, okay, and we are going to do this together. That's a ton of hospitals. That's a lot of people that have stake in that region. They all decided to band together to do this universal screening program. And again, they were able to show some really impressive results that no other community has done so far. And then we know that this is important because if we can start these non-pharmacologic bundles earlier and identify moms as they come into the hospital, or hopefully prenatally, you know, we can anticipate the level of care that they're going to need. And hopefully these kids aren't going to need to go on these long morphine weans and additive medications, but we can really treat them aggressively, non-pharmacologically, get them out of the hospital sooner and into their medical home. So the big key word is everyone, okay? Are we all going to buy in and do this, okay? Are we going to put the names on our badges and cover them up and all say, yes, this is a problem, we're gonna do this together? And the overwhelming majority of the Cincinnati experience has been, this was so important that we determined it was an all or nothing situation. They determined that this was a medical health crisis that required a different approach, and one that has been very successful. Okay, so again, we talked about the ability to catch newborns and then get them into a safety plan so that we're not letting kids fall through the cracks. We are extremely lucky in this community to have a very collaborative Department of Children's Services. Okay, Michelle Savio is here today, and she'll be able to answer more questions. But I get all the time when I talk about this at other locations, that's a big hurdle, is a collaborative experience with their DCS. We are very lucky in Allen County, I know everybody else has their own DCSs, to have a very collaborative response where they have reached out to us and say, yes, what resources do you need? What kind of communication do you need? And we've been able to establish that, and we'll talk a little bit about that as well. Let's see here. Sarah talked a lot about that together. Just to go back real quick, we'll talk a little bit about this later, but that last bullet point is another thing that Allen County is doing that no other community in the state is doing, is establishing a pilot protocol for appropriate follow-up, so where we are coordinating the care from the nursery with the pediatrician, DCS, the judicial services, as well as the developmental services, and Heather Wolf can talk more about that, and bundling all of that together. So this is something very unique that our community is doing, and there's been a lot of effort behind that. So again, this is just something that we know. The first, Rafting 101, does anybody know rule number 1, rafting? What, I heard it? Stay in the boat, okay? We're going to do this, okay? We are all going to stay in the boat. This is not going to be easy as a community, okay? This is something that we're going to get some resistance probably from administrations every now and again, but we're going to keep our focus in mind that this is a medical health crisis and that we've all got to do this and approach this together. So we've got Dr. McMahon on board. She's piloting our ship. She's leading the way. We have Lutheran, and Krista Peak said that she's going to do this. Patty Bray and Tom Miller of the OB service line, they've jumped on board and said, yes, we're going to do this. And then all of our professionals from OB, GYN, NICU, hey, there's Heather too, yeah. And then tons of other services really endorsing this process. So we're really excited to move forward with this. And again, this has just been an amazing collaborative experience where everybody has raised their hand and said, what can I do to help? So it's wonderful that you guys are here and taking this issue to task. And yeah, we expect great things. So thank you. I have about 10 minutes. Yeah. Oh, great. Okay.
Okay, we're going to speed this up. But first thing, I neglected to introduce myself. I'm Laura Dwyer from the St. Joe Community Health Foundation. Pretty sure I know most of you. So glad you're here, and thank you to Parkview for sponsoring the lunch today. So this is our fabulous panel. They are on your agenda as well. They're going to introduce each other. Obviously, you know Tony and Sarah. So we'll start with Michelle. They're going to tell you what their role is and what they're doing in the community and how they're addressing this issue.
I'm Michelle Savio. I'm the local office director with Indiana Department of Child Services here in Allen County at the Fort Wayne office. We have been working with the Neonatal Abstinence Syndrome Work Group and talking about this as an issue because we do see a lot of reports since everybody's a mandated reporter. If a baby tests positive for drugs, we're responsible to do assessments and really go in, look at that family situation, find out what services that they have, what resources they have, to determine what needs to happen with that mother and baby. We know that the worst thing that we can do is to remove a child from their mother at that time in their lives, but sometimes if we can't determine how to keep that child safe, that is a necessity. And so our goal is to figure out what resources we can find, what kind of cooperation we can get to try and maintain that infant-parental bond at that early age. And so that's what we're doing in this partnership.
Hi, I'm Heather Wolf. I'm a pediatrician, and I started out a few years ago doing the neonatal follow-up program at Lutheran Children's Hospital. So any baby who spent time in the neonatal intensive care units at St. Joe, DuPont, or Lutheran ended up coming to see me to be followed for growth and development for risk factors. And we found pretty quickly within the first year and expanding, anecdotally very quickly over the last 3 years, that one of our fastest growing diagnoses was NAS, was neonatal abstinence. So that quickly threw me into figuring out what the special needs for that population were. And then that has grown to, we're soon going to actually separate out our NAS population and have a NAS follow-up clinic. So I follow those babies who are diagnosed at this point with NAS and pretty soon with even just fetal exposure for the first 3 years to support the pediatrician. The beauty of our clinic is I'm blessed with a dietitian, a social worker, occupational therapist, physical therapist, speech language pathologist, lactation consultant. And so it's not me they're coming to see, it's this team of people who really can surround a mom and provide the supports that are unique to that mom and baby dyad and what they need. And so as a former I am a general pediatrician, but I used to practice as a general pediatrician. It's just such a huge expansion of services so that they have their pediatrician as their medical home for their primary medical care, but I can just layer onto that all of the needs that the special family mother-baby dyad may need.
Great. Questions?
Yeah, currently we take referrals straight from the NICU, from our neonatologists. So if a baby is diagnosed with NAS, so has withdrawal symptoms, they get the diagnosis. Basically, if the mom has a positive test, baby is screened for and watched for signs of withdrawal. If baby has withdrawal and goes to the NICU, they're an automatic referral to me straight from our neonatologists. If there's a fetal exposure diagnosis and baby doesn't have withdrawal symptoms, then our pediatricians can refer into our clinic, and then Sarah refers patients to me as well. As soon as we get our NAS actual clinic day up and running, then we'll be able to accept referrals from anyone in the community. Mm-hmm. Right now, yes. Mm-hmm. Yes.
Yeah, and one of the things that we're really working on from a pediatric standpoint is establishing a consistent follow-up plan for these babies. So the big one that we worry about are the babies that are exposed to narcotics, and we don't know if they're going to have delayed withdrawal or small symptoms of withdrawal as they progress. And the nice part about a pediatrician is that we're going to see that kid like 9 times in their first year of life. So what we're doing is every baby that is exposed to a narcotic, whether they have NAS or not, is going to get a standard letter talking about the symptoms of withdrawal and their expected follow-up. So they and if they are not meeting those follow-up criteria, a couple things can happen. One would be that we would reach out to our DCS as our safety net net to make sure that these families are still, that the babies are still safe. The other one is making sure that the babies, if they're having symptoms, are quickly referred to either Dr. Wolf or Dr. Bergeron in the developmental clinics. But I mean, we are so lucky that we have these systems in place where we can actually send these babies for further care.
I should say my counterpart at Parkview, Dr. Bergeron, is developmental pediatrician at Parkview, and so there's access there as well. And while I say we're limited right now, if there's a family who's in need, just call our clinic. We find ways to get them in.
I have a couple questions. So Dr. Bergeron, is that if there's a baby in the NICU that has NAS, then she automatically gets that referral?
I don't know what happens.
I think the answer is yes. I'm almost positive that the answer is yes. At least my talks with Dr. Rice, that's how that referral system takes place.
I have another question, and you sparked my memory of this, and I thought I would, since we have a bunch of pediatricians up here, I thought I would ask. And it does kind of tie together. Since you see a mom 9 times within that first year, typically, what would be the chances of you doing an Edinburgh at those well-child visits?
That's part of our protocol. I mean, AAP recommends Edinburgh, around 1 month, but absolutely these, the discharge letter states specifically that these moms are at high risk for perinatal mood disorders. So doing an Edinburgh screen, what I recommend is always at 2 weeks, although, there could be an argument to do that earlier as well. Because the big issue is that these moms don't get screened by their OB a lot of times until 6 weeks. And by that time, we know, postpartum depression usually peaks right around 2 weeks. So, that is a great concern, and one that we've really tried hard to address. I know that the Lutheran has a really wonderful perinatal mood disorders class, and so does Healthier Moms and Babies. Great. Well, and Paige. Yeah, oh, that's really great. And Paige, that's something that we're really working on, a consistent educational packet for these moms, and so that we're really working hard using the book that Meg Dissler created to implement a lot of those resources into a standard NAS educational packet. And Meg's been really gracious to make sure that we can use a lot of her resources for that.
We do an Edinburgh at every visit for the first 6 months in my clinic. The other thing that we're doing, that we're hoping to do over time, is really put together not only an education packet for moms and families, but for pediatricians in the community as well. So one of our goals is to really better communicate as a team around a baby. So, whether it's from DCS to the general pediatrician to the developmental clinic where they're going to any other pediatric subspecialist, a lot of these babies have confounding medical complications. They may see a pulmonologist, they may see a cardiologist. And so improving the communication that occurs between those different service lines and figuring out how to educate each other. So if you have high Edinburgh scores at one office, if that happens at my office, making sure I talk to the general pediatrician, back to the OB, and kind of putting it all together. So that's one of the jobs of this task force, is really figuring out how we can communicate better to take care of patients.
Has anybody ever thought about, I know Indianapolis, they're working on something where it's kind of like a joint EMR where it all feeds into each other. What are the possibilities of something like that happening in our community?
Pretty low. I mean, if you want to know the truth.
I think
It's like
Cerner is going live in
Cerner's
like 2
going
weeks,
live at,
so
yeah,
unless
Lutheran.
you put the halt on that, and yeah.
But there are other ways to communicate.
There are, yeah.
Yeah.
Absolutely.
That's like a huge thing in Indianapolis, and even Nurse Family Partnership is looking at putting our records into this database that they're doing with ISDH. So if a doctor pulls up at a pediatric appointment, and they can see our case notes, referrals, things like that. And then we would also be doing that for our prenatal home visitation program as well. But if no doctors are going to be on board and even being in this system,
I don't think it's necessarily that people don't want to be on board. So I'm lucky because I have privileges at all hospitals, so I have access to the Lutheran and the Epic side of things, which, I mean, if everyone had access to both, that would be helpful. But when I have 15 minutes for an appointment, I can only look in so many places for the information, which is frustrating, and I hate that. But, I mean, if we had something in the ISDH and I knew to look before the patient comes, absolutely, that would be awesome. Mm-hmm. I mean, I'm family practice. I can see them for the rest of their lives. Okay. I'm lucky because most of these babies stay with me. I mean, I refer them to Heather for the consults, but I get to keep most of these babies, which is awesome. So I get to stay with the mom, stay with the baby. Now, if they continue the medication-assisted treatment with Suboxone after delivery, there is a limit to how many patients you can have. I'm very far from that limit, but at some point I'll have to refer them somewhere else for those prescriptions so that I can still help the pregnancy ones. But at this point, I mean, I'll follow them forever.
I have a question, probably more for Michelle, around sometimes these are complicated family dynamics. And so I understand that if they don't show for the appointments, then they're going to contact you. But what kind of social supports can DCS offer these families to keep them from falling through the cracks?
Well, when the baby is born, if that baby tests positive for any drug, they're going to refer it to us at that point in time. So one of the things with this protocol is that we're going to have we've training our case managers to make sure that they're checking with the pediatrician to make sure that child's getting their well child visits, that they're looking at the whole family dynamics, like if they have an older child, is that older child going to school? So that they're really trying to look at the whole situation. And then they're really looking at also bringing in family supports that family may have, or informal supports, to look at who can help and support that mother as they move forward, as they're making determination whether that child can stay at home and whether our long-term involvement is necessary. And so what we look at then when we determine whether we're going to be involved with that family long-term is what are their protective factors that they have in place? Who is available to help be that safety net for that child? What services has that mother reached out, and is she following through? Are those parents following through? If not, we're likely to do either an informal adjustment and follow that family for 6 months and work with them and make sure they get services, or even a CHINS. If those protective factors are really strong and they've got good family support, we may not maintain our long-term involvement, but we're really looking to, during that 30-day assessment, to try and identify all of those dynamics and see what's going to be best for that family. So does that help? Because we're really looking at making sure that those services are in place, whether they be Network for Safe Families, making sure those pediatrician visits are being made, and really making sure that family's following through, because if they're not, that's when we're going to step up our involvement.
So I have another question, just because I'm curious, but I mean, I think it's working in the Allen County area, but a lot of community hospitals, and I'm on the FEMA review team, so we have a lot of women presenting community hospitals, which are lower level care. So if I'm in ED, whether I'm a physician or a nurse, and I suspect that the mother is there's been drug use and the baby is going to struggle, what is the right protocol for them at a community to get them into your services and into this network?
Well, I think one of the things for our involvement, the baby has to be born. And so DCS can't get involved until that child's born. So if you have a mother or a woman showing up who's pregnant, that's not something that we can get involved in at that point. And maybe somebody, doctor, can answer those questions. But once that baby is born, if that baby tests positive, they should automatically be making a report to the DCS office in their community for follow-up.
So in terms of the prenatal care, I mean, people can refer, and people have referred. Like, I have a patient who's living in Ohio who comes and sees me. If the patient wants to continue, I mean, I'm happy to, if the physician, contacts me, I can see the patient for a consultation and then give my recommendations for the rest of prenatal care. I'm whatever works. I mean, I'm more than willing to help physicians from any team learn how to do what I'm doing, because, I mean, it just needs to be done. So if people get into my clinic, or even, if physicians just call, we can work something out.
Can you explain a little more what universal testing might look like? And many of the people in this room have very close relationships with high-risk pregnant women who may be afraid of that.
I mean, ideally, universal screening will start in prenatal care, but I think our initial push is going to be anyone being admitted to any hospital gets a drug screen on admission, just as a starting point. And that way we're at least screening women at delivery. But ideally, when we get the prenatal panel with women, the urine culture, blood work, stuff like that, a drug screen will be part of that. And I mean, I test all my patients at every visit, and they know that, so.
I think that one of the focuses for those of us who care about this population is that we don't start universal screening until there are services that are done in an appropriate way that we can provide to those mothers in a non-judgmental, healthy environment, so that we can say to moms, yeah, this is just another thing we screen for. Like we screen for HIV, we screen for syphilis, we screen for these things. You're not likely to have syphilis. I mean, you could nowadays, but not likely to anymore. You're much more likely to have a substance use disorder. And so this is just another medical thing we're screening for because we have an answer. If you screen positive, then we have services to provide you as a pregnant mom that will help you with your substance use disorder, that will support you with your medical condition. And then when you have your baby, that baby will have services. We will have a clinic, you'll have your pediatrician, you'll have a follow-up clinic where you can get your services. So it's not about screening you to chastise you and take your baby away and give it to a better family, right? That's not the point. The point is to screen you so that we can treat you, so that we can provide the best treatment we can for you and your baby, so that we can maximize the outcome for you and for our population as a whole. So we're trying not to do this in a vacuum, like we're going to just screen everybody and then, oh my gosh, what are we going to do with these kids, right? What are we going to do with these moms? It's really about having the services in place so that we can reassure moms. If you screen back positive, just like if you had diabetes, we'd send you to an endocrinologist. Well, you have a substance use disorder, we're going to send you to a physician who specializes in that and have those services to follow.
Yeah, and I'll say, part of this process is relieving the stigma of substance use disorder. Okay, we're going to say as a community, this is a disease, it is not a moral failing, and you have a substance use disorder, we want you to continue to come and get your care. And so that's going to rely on the OBGYNs, to know that they're going to get screened in the hospitals. So what work are they going to put up front to prepare moms for that? Are they going to prenatally drug screen? That might make sense, okay? I think Sarah would argue that it certainly would. Or are they just going to say, listen, any hospital you go to, okay, to deliver your baby is going to be enveloped in this care where we're going to screen you and we're going to do all the things that Heather eloquently said. So yeah, it's a great question. It appropriately might make some moms nervous, and so that's why the community has put in the work ahead of time to make sure that this is done in a safe and appropriate and effective way.
And as Sarah said, it's going to take some time for our community to build trust. I mean, we're going to have to, but I think that's why we're involving DCS from the beginning with the task force, and we're all going to be on the same page, so we understand, what are the consequences when moms don't follow through, so we can be clear in our treatment that these are the expectations, and as long as we follow through the expectations, then here's what will happen.
Can I actually offer background? Anybody may comment on this in the room, but I loved your boat, the raft, but I think you should be building a bigger raft.
You want on the boat?
Yeah.
Megan's
Get
on
the boat.
I think every agency in this room has a trusted relationship.
Yeah.
That does just what you're saying that could really make a difference. So I would say, I looked at the through, but if this goes forward, maybe we can come back as a little bit further, but how do we engage everybody in this room? Because, Ann, you said you've got 900 babies coming
Right.
online, that they have a trusted relationship, and you see them, how many times in a typical family? 10 times.
Wow.
And I think similar with the Hope Center, and there's a lot of, they have great relationships that are great extenders. They've got those.
One thing that's going to be going out in in a few weeks or so is a survey, and the questions are particular to different fields. So I want the behavioral health treatment will be getting a separate survey. All the questions are written up. The pediatricians, the OBs are getting a survey, and they're all really to gauge our readiness and our thoughts and attitudes towards substance use disorder. So what I hope to do is actually, that's a great idea, is I'd love for as many people in this room to fill out that survey as well. Once we get those results, we'll really be able to identify some of our gaps in our perceptions about this. And then what we'd like to do from there is really have a symposium sometime this summer to gather all of our specialties, our OBs, pediatricians, NICU, and behavioral health treatment folks, and get them all together where we can really say, all right, we're in the boat, let's go forward. And I think that's exactly right.
Yeah, you want to answer that? And
I
then
can
I'll
answer
finish
why
it
the
out?
testing, yeah. As it stands right now, at this moment, in the Lutheran Health Network system, testing is triggered by certain diagnoses. So if you went into preterm labor, if you had a placental abruption, if you had, if the baby is showing signs and symptoms of withdrawal, they go back. And there's a list of medical things that occur.
Poor prenatal care.
Poor prenatal care, if it's the first or second time you've shown up. So there's a list that triggers that. So it would be one of those items that would have happened. But it could be as little as 36-week gestation, prenatal or prematurity could have triggered that. Right now, all umbilical cords are saved in the Lutheran Health Network. So umbilical cord testing is done, and those cords are saved for a week, so that if the baby starts showing signs and symptoms of withdrawal, because it doesn't usually happen in the first 24 hours or by the time the first meconium comes, then they will go back and test the umbilical cord. So, and then if there is THC positive in any of that, then we call DCS.
And what happens is it doesn't matter what kind of drug is in that. If it's an illegal drug, they're going to call us and make a report, and we're going to conduct an investigation. We look at all of them as, as serious, and will likely substantiate and will substantiate if that baby's test positive for drugs. However, substantiation does not necessarily mean removal. And so what we're going to look at is all of those other factors about what's happening with that family. Did the mom follow through prenatal care? What's their substance abuse history? How honest are they and willing to talk about services that they may or may not receive? And are they willing to do a safety plan so we can find supports for them as they move forward? Our last goal is to remove that child. If in many situations, especially with marijuana, because the mom will say, I was using it for nausea. I've seen that a lot lately for nausea, or because some of our other states, like Michigan, has medical marijuana cards, and maybe somebody came from Michigan. We had one who said, my prenatal doctor in Michigan knew I was taking it and didn't seem to be concerned, so why are you concerned? Well, we have to still treat that as a drug-exposed baby. But then we look at, can we design a safety plan with those supports so that our long-term involvement isn't necessary, and that family can move on and move forward with caring for the baby. What happens if our case manager decides that they want to substantiate a drug-exposed baby but not take a case, it then goes through their supervisor and through me as the director, and then even to our regional manager to take a look at that to make sure that that baby is going to get the supports and that baby is going to be safe and before a case can be closed without our intervention. If they determine our intervention is necessary, most times, as long as the family is cooperative, they're going to leave that child with the mother, and then maybe either do an informal adjustment, which is a period for 6 months, or they may do what we call an in-home CHINS, which is a child in need of services. We're more likely to do that CHINS if the family is not cooperative, because they haven't been willing to work with us, they haven't been upfront, or we haven't seen a decrease in their drug use through the 3 drug tests we've given them throughout the 30-day assessment. Because we're going to give a minimum of 3 drug tests during that assessment. We're looking to see are the levels going down, or are they increasing, what's the drug use going on. And so we're looking at all of those factors as we make a decision and where to go from there. But if the hospital calls in a report that the baby tests positive or the mother tests positive when giving birth, we're going to open assessment.
I mean, if we suspect alcohol use or there's been alcohol use, you can do an alcohol test, but it's not part of the general panel. It's just drugs.
It could impact her because a substantiation stays on somebody's record for, right now, forever. The law has changed. It used to be when the youngest victim got 25, it would go off the record. But it could impact employment, like in a school or a child care setting. If we substantiate, people have the right to appeal that substantiation through an administrative review or even through an administrative law hearing. But if the substantiation remains on file, it could potentially impact their ability to maybe provide care for a family member later on. School could impact their career choice because they are likely not able to work with children unless they get a special waiver for that.
Okay, let's give our panel a round of applause. Okay, so if anyone wants to take a tour of Healthier Moms and Babies, find Paige.